Hello, my name's Craig Webster. I'm with the School of Medicine at the University of Auckland in New Zealand. I also need to disclose I own a small number of shares in a company called Safer Sleep. Medication administration error remains a leading cause of patient harm in healthcare and anesthesia. In the last 20 years, there have been a number of large-scale studies aiming to reduce medication error. There's also been, in more recent times, a number of review studies looking at the efficacy of these intervention studies. This one by Kears in 2014 concluded that it was emerging evidence for safety interventions and called for more RCTs. This one, just this year by Maximus, concluded that multifactorial safety approaches reduce medication error in anesthesia and called for more RCTs. So the first RCT was published in 1948 in the British Medical Journal. When you're comparing drug A with drug B or drug A with a placebo, then an RCT is an ideal method to do this. The methodological assumptions underlying RCTs include the following. Randomization should be preferably performed at the level of the individual patient. Practitioners should be blinded to treatment and control groups so they can't influence the outcome. Treatment should not contaminate control groups. And the treatment should directly affect the outcome measures. And this is relatively straightforward when you're injecting a drug into someone's bloodstream. The situation for stopping adverse events happening or improving safety in healthcare is not quite so simple as this causal map of clinical adverse events kind of demonstrates. I don't expect you to follow all the little blue arrows here, but the point is that this is a very nonlinear system. On top of this nonlinearity, safety interventions are often iterative. So they're often improved and over time so that the treatment isn't always exactly the same. They're often rolled out to all patients in a hospital progressively over time so that maintaining control in treatment groups isn't easy. So let's think about those methodological presumptions again in terms of safety studies. So the first one, a randomization should preferably be done at the level of the individual patient. This is often not easy in the situation of a safety study where you have to set up on a treatment environment for the new treatment and then change it for the control. Often this has to be done on a daily basis or a weekly basis. So basically you're randomizing at the level of the cohort, not the individual patient. Practitioners should be blinded to treatment and controls. Well, in safety studies, practitioners are aware of who's receiving standard treatment, who's receiving the new, safer treatment. Treatments should not contaminate control. Well, often practitioners like the idea of the new safety intervention, and so they start using it on all their patients, including the ones in the control group. So that contaminates the control group. And as demonstrated by that causal map of accidents, there isn't a linear connection between independent and dependent variables. There's lots of other kinds of things which can intervene and stop that from happening. So most interventions involve approaches that have been shown to work in other domains in terms of safety. So we've got color coding, bar coding, better workspace layout. It wouldn't be, we would expect these to work in healthcare. They're not a brand new thing. Why do we need RCTs to demonstrate safety improvement when they are not used in other safety critical industries? I mean, the aviation industry does not use RCTs, despite the fact that healthcare draws safety lessons from aviation. Neither does nuclear power and many other industries. And also we know that global safety change can occur without an RCT being involved. The two prime examples of this are Gowani's work with the surgical safety checklist and Pranavost's work with central venous catheter bloodstream infections. Taking this to a sort of parity level, there was a paper published in BMJ a few years ago suggesting that we should give up parachutes. Parachutes used to prevent death and major injury related to gravitational challenge. They concluded there was no RCT evidence for parachutes. So, what is the threshold for evidence we need before we adopt something? And pulse oximetry, there have been large Cochrane reviews that have shown no benefit of pulse oximetry at all. Yet we don't want to give up these technologies. Looking at a couple of multifactorial interventions that are included in these reviews. One was by our group in New Zealand. Our multifactorial intervention included the usual things like pre-filled syringes, better workspace layout, color coding, and so forth. We looked at 74,000 anesthetics, and we showed that there was a significant reduction with the new system compared to conventional methods delivering anesthesia. We converted these comparisons to administrations. So we had 58 errors in 183,000 administrations in the new group and 268 in over 500,000 in the conventional group. And that's a 35% reduction in error per drug administration. We also looked at subcategories, and there was a 66% reduction in drug errors between classes. So syringe swaps between drug classes were reduced by 66%. This is a good thing because obviously swaps between classes are potentially very dangerous. We also did a one-tailed test on actual outcomes. So looking at cases of major adverse outcomes, we had none in the new group and 11 in the conventional group. And looking at what those adverse outcomes were, we can see that they're definitely things you'd want to prevent. Prolonged stay in the ICU, awareness, anaphylactoid reaction, and so forth. Another study worth mentioning is the University of Washington study, also a large multifactorial intervention. They used Shewhart charts to track their progress. So at the first point, they introduced smart infusion pumps, safer syringes with color coding, safer barcode technology for identity checking at the second intervention point there. And they showed a 63% reduction in medication administration over the period of their study, which is pretty dramatic. Focusing on adverse events as the outcome is consistent with Safety 1. Safety 1 was an approach to safety which developed in the early industrial era. This is a Ford Motors assembly line here. So this is definitely a Safety 1 environment. And if you look at Safety 1 safety principles, it's find problems and fix them, often using root cause analysis. Report failures, which is incident reporting, and standardize processes to make them less error-prone. This actually is what we're generally doing in healthcare, and these are common in healthcare still. So under Safety 1, the definition of safety is that there are fewer accidents, there are fewer bad things happening. But in more complex socio-technical systems, with that non-linear causality involved, this picture is not quite so simple. The top one there is Safety 1 causality. You expect it to be linear. Safety 2 causality has many loopbacks, and you're not sure how many steps are involved or how long it's going to take. Safety 1 is about, in Safety 1, failure occurs from a malfunction in a linear causal sequence. Under Safety 2, failure occurs from an unexpected combinations of everyday performance variability. And actually, that means that things can go wrong when there's no broken parts in the system. This is much more like what happens in healthcare. If we think about the outcomes from any particular kind of healthcare intervention, they can either land on the zero line, which means they come out exactly as you planned, or they can come out better, which means they end up on the green side of this chart, or they turn out worse, you have complications and it takes longer, and they turn out on the other side, which is the red side on this chart. So you get a sort of distribution of outcomes, and this would be expected. You would expect to get a distribution of this shape. So on the other side there, on the red side, that's things that are right, go right, but are difficult. So Safety 1 basically treats only the red tail of this distribution. This is the adverse events. These are things that went so badly that they're called adverse events. So Safety 1 says we should get rid of this tail. Organizational headwinds also push the shape of the distribution in that direction. So things like production pressure, shortage of staff, lack of ability to plan ahead, etc., push the distribution in the direction of the red tail. Safety 2 is about considering this part of the distribution. What can we do in everyday variability to improve the overall performance? How can we make things that go well or things that go good go even better? So, what kind of measures can we take from this middle part of the distribution around process? These could include self-report, observation, rating scales, outcomes data, to actually push the distribution in the other direction. So we get the mode of the distribution moving in the other direction towards the positive end of the distribution. If we do both of these things together, take safety 1 and safety 2 approaches together, we've got a much better chance of making good progress. So conclusions, consider the context of safety interventions and their evaluation. ICTs are useful tools, but not every job needs a hammer. Advances in medication safety have been made. Multifactorial initiatives do work. However, more evidence is needed, and often it's around compliance with new safety initiatives. Why don't people use them? And complex systems have safety 2 causality, and that includes healthcare. Safety 1 approaches are not sufficient on their own. We should consider measures to improve everyday functions, not just reduction in rare adverse events. Thank you.